Hello, everyone. My name is Bethany Hamilton. Welcome to today's National Audience webinar presented by the National Center for Medical Legal Partnership based at the George Washington University. You are joining us on March 6, 2025. If you're on the East Coast, it's 2 p.m. Eastern Time. Our webinar today is about partnering with public health to reduce indoor asthma triggers and improve asthma outcomes. Our guest today will help us focus on what they're doing on the ground in Ohio. So we are using Ohio as a case study to present today's content. Next slide, please. Just some quick housekeeping. As you know, you're joining our webinar today on mute, but please feel free to engage with us using the Q&A or the chat. Occasionally, we may engage the audience and ask you to interact by responding to some chat-based questions, and when we will call out, depending on the size of the group today, we'll call out some of what came through the chat. So please feel free to engage either via the chat or the Q&A. When you do engage, try to use the everyone setting to make sure everyone in the audience can also see what you are, how you're engaging and how you're responding. But if you need to reach us for assistance, use the host and panelist selection in the chat, and we'll provide you with some support. All right, if you do need to activate captions, utilize in Zoom the more options to get live transcript and show subtitle to show up, and the caption should appear. Again, if you need assistance with that, send us a chat to the host and panelist. And then finally, because we know folks do ask, and we want to make sure that this resource under the current circumstances continues to be made available via our websites. We are recording this, and it will be made available on the medicallegalpartnership.org resource page. All right, let's go to the next slide. And folks will see that Reha is plugging information into the chat. Okay, so the reason why we are making sure that folks really have access to this recording and the resources is because we know that some of our communications that come through the funding source are down at the moment. So we want to make sure that the funding that supports this webinar and several other resources that we will be producing over the next few months is HRSA, the Health Resources and Services Administration. They're part of the U.S. Department of Health and Human Services, and the National Center for Medical Legal Partnership has been a training and technical assistance partner, utilizing funding from HRSA to support the development of resources and training and technical assistance, primarily for health centers to be able to start medical legal partnerships and implement those strategies around the country. The contents that we present, as well as our guests today, are those of us as authors and do not necessarily represent the official views of or should be perceived of or interpreted as an endorsement by HRSA, HHS, or the U.S. government. For more information about our funding source, please visit hrsa.gov. Next slide. Okay, as I mentioned at the top of the webinar, I am Bethany Hamilton. My title here at the National Center is Director, and the National Center for Medical Legal Partnership is based at the Milken Institute School of Public Health at George Washington University. I want to welcome everybody to our training event. Next slide. Today's training event really takes us to the classic story of medical legal partnership and what we use often as a way to explain the role that partnering between healthcare or health systems or public health and legal services organizations in the community can do. Several folks have probably heard the classic example of MLP, where a child might be with a parent at the pediatrician's office, and that child suffers from asthma. And there's nothing that seems to be working medically to treat that case of asthma. It's worse. There's some sort of triggers in the home or in the environment, and the medicine just doesn't work, and the child keeps showing up with this condition in the ER, and things are just worsening. And somewhere during the conversation between the provider and perhaps the parent, it is revealed that at home, perhaps there is mold or some other sort of problem, and the landlord hasn't fixed it. And that's when the healthcare provider realizes that there is some other profession out there in the community that is needed to actually address that health harming legal need. That is the classic story of medical legal partnership, or at least discovering that you need your legal partner in place to be able to address that problem and improve the health outcomes. You can see highlighted on the screen several examples over the years of how we've better understood how implementing a medical legal partnership can support asthmatic patients. It can reduce hospital admissions that are unnecessary because now you're controlling the actual problem that's triggering asthma. MLPs have also been able to work on pinpointing clusters of high asthma morbidity rates using housing and health data. They've been able to do that as healthcare and legal partners, and then be able to better address the issue more systemically. You can see any other example at the bottom of the slide that public-private partnerships, such as one that we're going to discuss today with a Department of Public Health, really brings in that multi-sector ecosystem for a medical legal partnership to similarly address problems that are more systemic in nature and don't just help one individual, one patient at a time. With that, I want to move to introducing who our special guests are today. Excuse me, sorry about that. Let me first talk about our learning objectives before introducing our special guests. On today's webinar, we're hoping that everyone in the audience can take away the following as learning objectives. We hope by the end of the webinar, you're able to better describe the connection between indoor as well as outdoor air quality and asthma. We also hope that you'll be able to explain what is called a MATH model, or Managing Asthma Triggers at Home model, including its collaboration with health providers and its evidence-based. Also, we're hoping you can better analyze how one community, such as our guest from Ohio will explain, are implementing the MATH model in collaboration with the county health department, a local children's hospital, and community health workers through a hub to better identify and serve families in managing asthma triggers. Then, because we have a lot of learning objectives here, we want to make sure everyone understands what you'll gain. We're hoping you'll be able to examine the natural partnership between local health departments and legal aid organizations. We're hoping that you'll then be able to identify the role of legal aid as well as one in your community, and the purpose of MLPs and the structure of MLP collaboration, and finally develop some strategies for integrating a local legal aid organization or legal services provider, perhaps it's a law school in your community, into a MATH model that can be carried out through a medical legal partnership. Okay, now I'll introduce our speakers. First, as you can see on the left, we are very happy to be joined by Sam Rubens, who's the Summit County Public Health Manager for Air Quality of Akron, Ohio. Sam is a huge champion for clean air and public health. As the administrator of the Akron Regional Air Quality Management District and a manager of the Summit County Public Health Department, he leverages his expertise in chemistry and public administration to spearhead initiatives that really get to promote healthier communities overall. He has over 30 years of experience, and he's a recognized leader in air quality and public health, collaborating with numerous organizations to tackle those critical issues such as asthma, indoor, outdoor air pollution, urban forestry, transportation planning, and climate changes. To address one of these issues, he actually created a program in collaboration with Akron Children's Hospital that he'll talk about a bit more on today's webinar, and that's really focused on helping children with severe asthma reduce asthma trigger exposure. On the right, you'll see that we're also joined by our special guest from the legal aid community, attorney Marie Curry. She's with Community Legal Aid in Akron, Ohio, and is a managing attorney. Marie is actually also the medical legal partnership director. Marie, let me know if I got that wrong. The medical legal partnership at the Community Legal Aid in Akron is called the Health Education Advocacy and Law Project, HEAL project. She manages legal aid's Learning is Everyone, or Learning is for Everyone, or LIFE project. And in addition to that, she directs client representation, where her team focuses on policy changes that can improve population health and reduce health disparities. She serves as co-chair of the Policy Research and Analysis for the Ohio Consumers for Health Coverage. That's a statewide organization really striving to improve access to affordable, high-quality healthcare for Ohioans. In addition to that, I should take a moment to note that Marie and I share something in common. In 2011, Marie served as an Equal Justice Works Fellow, where she got to focus on health and poverty law issues. And she also volunteered for the organization before joining as a staff member in 2014. She also received Dennis Murphy Award, which recognizes folks who are really doing outstanding advocacy within the Ohio legal aid community and organizations. Outside of her role at Legal Aid, she also taught health law and policy at the University of Akron School of Law. I want to thank Sam and Marie for taking time out of their very, very busy schedules locally and nationally to support our training webinar today. Okay, with that, I'm going to pass the platform over to Sam to begin the presentation and encourage everyone to share your questions in the Q&A and chat. Thank you.
So hi, everybody. My name's, like Bethany says, my name's Sam Rubens. I wanted to thank the National Center for inviting me to here to talk about my program, the math program. We'll go to the next slide. Just keep, go back one. Oh, we're missing one. Okay, anyways. So I want to talk a second about my agency. I'm the administrator of the Akron Regional Air Quality Management District, or we go by ARACMID. Even though it's a horrible acronym, it's the one we got. So we're the local air agency for a 3-county region around Akron, Ohio. We've been focused on reducing levels of air pollutants in the Akron area since 1948. We used to be the rubber capital of the world, where the 6 largest tire companies in the world were headquartered. And 2 out of every 3 tires made came from Akron. So there was never a shortage of pollution in the air. And when I was a little kid, I grew up just downwind of one of the Firestone plant, and we called it the smell of money. It didn't do wonders for our longevity, though. ARACMID's been part of the health department since 1965 officially, and we've been part of the Ohio EPA since its inception in 1971. We work together to fulfill our mission to protect the public from the adverse health effects of air pollutants on our public. We receive funding from the US EPA, the Ohio EPA, and local fees on our industry and our service area. These local fees are collected from facilities in Summit, Medina, and Portage counties, and that becomes important in a minute. But since 2016, the air quality that we're breathing here in our 3 counties has met all of the national ambient air quality standards. It's healthy. So our goal kind of changed from let's make it healthy to let's keep it healthy and see what other projects we can help bring on board to help citizens live healthier lives. So while we've long worked with our population to educate about air pollution, both inside and outside, we had a pretty tragic situation occur here. And so we took that opportunity to create something to improve the lives of our most at-risk populations, the Managing Asthma Triggers at Home program. And when Bethany was giving the introduction, the learning objectives at the beginning, it was funny hearing the math model, because it's literally a program that we came up with here at Summit County, coworker and I brainstorming how we could make this happen. So hearing it called the math model is pretty cool. Let's see, next slide. Now, there we go. So in 2019, the Asthma and Allergy Foundation of America came out with their Asthma Capitals report. It showed that Akron was the 14th worst city in the US for people with asthma to live. And this landed directly in the intersection of my professional worlds of indoor air quality, outdoor air quality, and public health. Our assistant commissioner at the time, health commissioner at the time, had been working with our primary pediatric hospital, Akron Children's Hospital. I'll be calling them ACH just because, we only have so much time, to identify ways we could collaborate more effectively. Right around that time, tragedy struck our community in that we had a child die from asthma, and another had such a severe asthmatic reaction that they had to go through intensive rehabilitation after their asthma attack. So that was just in Summit County. Across the state, there were 129 deaths from asthma that year. And according to the Ohio Department of Health, the burden of asthma is predominantly borne by children of color. African-American children are 9 to 11 times more likely in Ohio to have asthma than white children. So this was something we've got to get some way to make this work, get these numbers less disproportionate. Next slide. So I want to give a quick primer on asthma because not everybody's as far in the weeds as I am. So asthma is one of the most common chronic diseases of childhood. It's identified from coughing, recurrent wheezing, shortness of breath, chest tightness, and limitations of exercise abilities. Asthma impacts the child who suffers from it by missed nights of sleep, which lead to falling behind in their educational opportunities, and then the physical impacts of not being able to breathe normally or when exercising. But it's not just the kid that's affected, it also affects the entire family. Because if the kid can't sleep, a parent or parents are going to have to stay up, which means they're not going to be functioning their best at work the next day. The kid has to stay home from school, or worse, go to the hospital. The parents are going to miss work and or pay depending on their career. And if they're in the hospital and not at work, that can lead to reduced opportunities for advancement for the parents. And all of this because of something that's outside that kid's control. So, like I said in the last slide, the burden of disease falls radically on African-American children and also males over females. So, if a child does wind up at the hospital with asthma symptoms, the usual course of treatment is the doctors will examine them, provide an inhaled corticosteroid, which is the puffers. It'll help open up the airways and get the kid breathing easier. There's different levels of asthma illness. There's mild intermittent, mild persistent, moderate persistent, and severe persistent. And at Children's Hospital, or ACH, they had broken out a subset of those severe persistent asthmatics into a high-risk asthma list. Now, Akron Children's Hospital covers about 11 counties up here. So there's a lot of places that kids are living. But that list, their high-risk asthma list, had over 30,000 patients on it. And in order to be included on this high-risk asthma list, the patient had to have met one of three criteria. They either had to be in the emergency room for asthma 3 times, inpatient stays for asthma twice, or intubated once in the last 12 months. So that's pretty serious asthma effects. So because, like I said in the slides before, our funding comes from industry, local fees, we were trying to target our 3 county service area. So we did a deep dive on the list and found out of the 30,000 patients, there were about 300 that lived in one of our 3 counties. So that was our focus group. Those were the kids we were going to look at and try and help. We started discussing involving other groups in our community that would be good partners to further take this project moving forward. So we looked up, next slide. So SCPH, Summit County Public Health, and ACH began through the steering committee, the asthma steering committee at Children's Hospital. We identified actions that each of us could take to help these children with asthma. Each of us understood we had parameters we could handle and other things we couldn't. Our partners at ACH excel at their jobs. They analyze illnesses, address the symptoms, and get the patients back to healthy. But if the child goes back home filled with asthma triggers, they're just going to end up in the hospital again. So fortunately, we at Summit County, the health department, we have the knowledge and capacity to do home environmental assessments for asthma triggers. By bridging that gap and providing that wraparound service for the family, we could attempt to improve the child's health outcomes. So as the discussions began to intensify between our 2 organizations, we acknowledged that public housing and school environments might also have a part to play in the asthma trigger reduction arena. So we made overtures to bring in both Akron Public Schools and Akron Metropolitan Housing Authority to educate their housing inspectors about asthma triggers. Akron Public Schools got a grant opportunity with Ohio Department of Health to get some funding for school nurses, but that was kind of between them, and I don't have a dog in that fight. so I don't have too much information there. But we did start to work with AMHA inspectors to train them up to identify some of these so they can help without us even getting involved. Next slide. So in 2018, ACH and SCPH designed a pilot project to assist 100 families from their high-risk asthma list with their asthma triggers in the home environment. We had to get IRB approval because we were working with children who had compromised health issues. The doctors would notify us about the child. Then we contact the family to set up a home visit. When we get to the homes, we would do a walkthrough assessment of the home. We would educate the family about triggers and provide information on how to minimize them. We performed an asthma control test, a social determinants of health survey, and a personal safety survey with the family. At that point, we provided the family with a suite of equipment to help reduce the asthma triggers. The equipment we gave: bed and pillow bags, a HEPA vacuum, a HEPA unit, air purifier for the child's bedroom, furnace filters quarterly, dehumidifier if needed, pest control and home cleaning if needed, a spacer for medicine provision. That's the thing that you put between the puffer and the child. And we also provided a carbon monoxide detector because it's just good public health. It has nothing to do with asthma, but it's good for public health. So we would communicate with the family via text monthly with some sort of asthma messaging, just staying engaged. We visited the home every 3 months to check in, assess the home environment, see if anything had changed, and perform another set of questionnaires. The direct interaction we had with the family lasted for 12 months. And after the intervention was completed, Akron Children's Hospital did a chart review and determined how many times the child was admitted to the hospital or seen in the emergency room during the year prior to our intervention, during the intervention, and after the intervention. Just see if there were any measurable improvements in the hospitalization utilization rates. Yeah. We also tracked the ACT scores throughout the year of intervention and related that back to the significant improvement data. So if you know, the CDC has an Exhale program. They came out with the Exhale program kind of the same time that our math program came out, and thankfully they overlap. The Exhale program is educate, extinguish, get people away from smoking, home environment, achievement, linkages, and environmental resources. So it all kind of tied back together to what we were doing. We were very glad to see that worked out. Next slide. So I'm just going to run a few slides now of the research data we collected for the 88 cases. 2/3 of our clients were African American, a quarter were Caucasian. So we hit a target that we wanted to hit. Next slide. We collected a bunch of data, and on analysis, we came up with some surprising results. The majority of our clients lived in privately owned or rented single-family homes. We really thought that a lot more people were going to live in subsidized housing. So this was an unexpected result. Glad to see it, because it shows that our AMHA is providing high-density public housing that's not really creating issues for children with asthma. We did have one child through our partnership with AMHA, the Metropolitan Housing Authority. The child came through the hospital, was referred to us, and he lived in public housing in the basement. And if you know anything about basement apartments, they're not good for asthmatics. They're generally going to be more damp. There's going to be more likelihood of mold, all this kind of stuff. So we were able to work with AMHA and get them on a list to be prioritized to move them out of that unit into one that was above ground. Next slide. So another interesting data result was that the majority of our clients' families didn't smoke or have pets present. This was really good news for our program, because I don't know if you've ever tried to get someone to quit smoking or get rid of / restrict access to pets. It is not a good time. one of the big issues for our program was that if a guardian took the child to the doctor and that guardian had never smoked, so when the doctor asks, do you smoke around the child? The guardian gives a truthful no. But then when we get to the house and see coffee cans full of cigarette butts everywhere because everybody else in this kid's life smokes, what's a doctor supposed to have done? They operated under presumptions based on accurate but not complete information provided. So this is one of the big benefits of having my staff able to go out and do these home visits, because we can actually see what's going on instead of just what's being provided. Next. So like I said, the asthma control test, the ACTs, are self-assessments of the child's asthma control. Some of the sample questions are, how much did your asthma keep you from getting things done? Have you had shortness of breath? Did you wake up with wheezing or shortness of breath? How would you rate your asthma control? These type of questions, and you get a score on each question of 1 to 5. So the total score would be 5 to 25, with higher being better. From research, we found that a 3-unit increase is just considered to be a significant improvement. Overall, the 88 clients, the ACT scores moved up by 3.8 units, from 18.6 to 22.4. And that indicates that the clients had better nights of sleep, more ability to pay attention in school, and ability to exercise more because their asthma was better controlled. So that was a big push for us, so that the families felt like the kid was feeling better. Next slide. But while asthma control test improvement is good, declines in hospital usage is even better. We saw inpatient hospital stays decline 62%, and emergency room visits declined by 77%. This reduction in need for hospital care led to less missed school and work, and less stress on the family from medical bills. Next slide. Now, translating that over into dollars, we used estimated costs, and these were a few years old, so don't laugh at the $9,000 for a hospital stay and $500 for the emergency department, but that's the consistent number across all 3 of these columns. We went from $528,000 worth of medical hospital use costs to under $200,000 in the year after the intervention. So that's a 2/3 decrease in costs. So that was pretty huge too, because it leads us to our next process. Next slide. So when those intervention years were complete and all the data was collected for the post-intervention hospitals usage, Children's closed the IRB approval and we moved to a service provision model. And that's continued to this day. We still work very hand in hand with our hospitals and trying to help the clients. ACH also recognized that there were a significant number of patients over in the Youngstown area, which is about an hour east of here, that were on their high-risk asthma list. So we began working with Mahoning County Public Health to create their program modeled after our program. Mahoning County identified funding to operate their program in late 2023 using some ARP funds. And in 2024, the hospital began referring kids to Mahoning County. Because they didn't have an easy way to get the referrals over to them securely, we had just already had the EPIC referral path established between Akron Children's and us. So the hospital refers them to me, I fax them over to Mahoning County, and the kids get addressed that way. But as the program, both the staff time and the equipment was being paid for using air quality local fee funds and saving costs for the managed care organizations, we started trying to figure out how we can get a way so that the equipment costs could be covered by the managed care organizations. So in 2024, we connected with our Pathways Hub at Community Action Akron Summit, and they hooked us up with Buckeye Health Plan, which is one of our state of Ohio managed care organizations, Medicaid payers. So over the first quarter of 2024, we built up a procedure for referrals, assessment, equipment provision, just to make sure that everybody was on the same page. Very similar to math. and we started implementing it in the second quarter of 2024. All three of us have been operating this program, and to date, I think it's over 100 kids now have been enrolled. And the preliminary data is showing great improvements, both ACT scores and reductions in hospitalization use. Buckeye is planning to expand the program into Cleveland, Columbus, and Toledo areas by working with their local health departments, hubs, and hospitals. Once final assessment of all the data is completed next year, Buckeye's talking about sharing their program with the other major MCOs in Ohio. And if all this goes down the way it sounds like it's going to, that would constitute over 38% of all of Ohio's children would be in some sort of program following the math model. So having our local health departments, hospitals, MCOs, and social service agencies working together to protect children who are afflicted with a life-changing disease to impact the quality of their lives has been an amazing opportunity, and it's one I'm honored to be a part of. We're constantly looking for ways to expand and improve, and part of that is more critically involving our friends at Legal Aid. So I'll kick it to my friend Marie Curry now.
Hi, everyone. All right, here we go. And I'm going to assume you can hear me unless somebody tells me different. And so if you could go ahead and I'm going to just dive right in. And I also want to thank the National Center. I've been working with the National Center since they were created. And it's a great, we are very fortunate in medical legal partnership world to have such wonderful colleagues helping us advance the model and bring these kinds of educational webinars to the group of you that are here today. So next slide, please. So I just want to give you a sense of what we're looking at here, just to place where we are, where Summit County, Ohio, and Akron, Ohio are. Click, please. This is basically central. I mean, this is basically the northeast quadrant of Ohio. And you can see Cleveland up at the top. You can see Pittsburgh, Pennsylvania down in the right corner. That's not far over our eastern border, and you can see Columbus down in the lower left. Click, please. Here's where Akron and Summit County are, right in that range right there. So we're about 40 minutes south of Cleveland. Click, please. Just to give you a sense of size, go ahead and click. So here's a close-up of Akron, and go ahead and click. Akron has roughly 190,000 residents, and go ahead and click. Summit County has just over 500,000. So that gives you a sense of kind of our population. You can think about it in comparison to your populations where you are, because in some ways we're a small population, but in other ways we are big enough to be able to get numbers substantially enough to see whether our interventions are having an impact. Go ahead and click. And just to also give you a sense of scope, Cuyahoga County is double the population, just over double the population of Summit County, and about a third of that population lives in the city of Cleveland. So that's our landscape. In Summit County, the city of Akron is the county seat, and it has its own housing code. So we've got Summit County and the city of Akron. Akron has its own housing code, and generally speaking, the health department doesn't enforce the housing code. Summit County, right, health department doesn't enforce the housing code in the city of Akron. If there's an issue in the city of Akron, that compliance comes through the housing compliance division within the city. However, Summit County does do lead inspections in the city. They overlap with the city on this because there's so much need in our community. Our housing stock is very old, so we have a lot of issues around lead. And as you know, or probably know, lead dust is an asthma trigger. In the city, so the differences between the city and the county are significant. In the city, we have much more landlord-tenant relationship in terms of residents. Outside of the city, there's less landlord-tenant relationship, more owner-occupied. Outside of the city, the health department does housing and health code violations, And the health department is not in a position to be able to be proactive. They don't have a registry for rental housing, for example, but they are reactive, so that if there's a complaint, they go out and inspect a residence, and then they issue orders if necessary. And all of that is significant from the perspective of, okay, what are your tools for pushing resolution beyond the individual level, right? Sam talked a lot about the health systems intervening and the health department creating systems so that the individual family members and the asthmatic person can make changes and improve their situation. Well, legal aid is attempting to go one level, at least one level out on kind of the ecological model. Next slide, please. So the health department and legal aid is really a natural partnership to improving health conditions. If we think about safe and healthy housing, we can look at three different buckets of concerns. First is unsafe conditions. Okay, what do unsafe housing conditions look like? Go ahead and click. They're things like housing code violations, broken locks. Go ahead and click broken windows. Unsafe stairs, unstable foundations, water leaks, those kinds of things. And then our second bucket, go ahead and click, is lack of heat. Right, these are unhealthy conditions. They kind of they have a different flavor than unsafe. They're lack of heat or electricity. Go ahead. Or refrigeration, right? These are housing code violations, or the presence of mold, which we know is also an asthma trigger. Go ahead and click. And that third area is a special bucket that's lead. And like I said, we have a lot of old housing stock in Summit County, and so lead is a significant issue. And we find that our people talk a lot about water in the lead in the water lines. That's not as much of an issue for us in Summit County and in Akron, and our pipes are getting replaced consistently and comprehensively, which is all good. But really, it's the lead in the houses that's the issue. And so we know that all three. I don't know if I have any. I don't think I have any more animation. We know that all three of these concerns result in unhealthy living conditions for residents. So Sam has focused on asthma triggers, but it can be much more than that. Go ahead. So really the question is, where is the synergy? When does the health department bring in legal aid? So we're thinking now about what is it that creates a good partnership between legal aid and the health department, in addition to our other community partners. And so the first thing I want to ask you to think about is, when does the health department bring in legal aid? Well, the health department might bring in legal aid when they're out at a property doing an inspection, whether as part of the math program or for some other reason that they've been called out, and they identify violations to the housing or the health code, and they really want to send this family to a resource that's going to help them navigate complex and often opaque legal rules about how to persuade the landlord to make the changes necessary in that rental housing for the person to live in healthy housing. And in Akron, we're really fortunate to have this triad with our health providers. So we also have a strong relationship with Akron Children's Hospital. Legal Aid does. That's our medical legal partnership. And but that's similar to the way you could have that kind of a strong relationship with your community health center. So if you are a community health center or an FQHC, this is the kind of collaboration that you can create to create a dyad, right? Whether it's community legal aid with the community health center, or this triad, which includes the health department. The hospital's there, or the medical provider's there to do the medical stuff. The health department helps with the environmental piece, and legal aid is there for the legal piece. And as you heard Sam talk about the family that lived in the basement, the child with asthma who lived in the basement apartment of public housing, in a situation like that, if there was a family struggling to get the housing authority to make the change that they needed, they might have brought in legal aid to help them negotiate that with the AMHA housing authority to help that happen. Right? Doesn't always happen as smoothly as you want it to happen. Doesn't always only take a phone call. When it does just take a phone call, that's great. So sorry. So go ahead. So then the second piece that we talk about with respect to the synergy is when does legal aid bring in the health department, right? So we just talked about when the health department calls in legal aid. So legal aid will bring in the health department typically when there's a landlord-tenant problem, and when there's a problem with housing, and we see that come in through our front door, or maybe we see it come in through our partnership with Akron Children's Hospital. One of the first questions we ask is, has the health department already been out there and already done an inspection? And if they have, then we get a hold of that report and we see what kind of leverage we can use on behalf of the tenant to, again, persuade the landlord to make the changes that are necessary for that housing to be healthy. But what legal aid does at that point is very it's strategic, right? We can't just go off and call the landlord and say, hey, you have a housing inspection that says you're supposed to do all these things, please get on it. Because you really need to be thoughtful about, as lawyers, we need to be thoughtful about what that relationship is between the landlord and the tenant. If the tenant is the tenant up to date on their rent? Is the tenant month to month? If the tenant asks for something for the landlord to do, is the landlord going to terminate their lease, right? And then again, how comprehensive is the housing code? Is the violation something that's clear, that's going to be easy to prove? So there's all these considerations that play into the decision about what strategy to use to respond to the problem. But the collaboration with the health department is one of the tools in that tool belt. Go ahead. And so just to take a minute with lead, because lead has its own set of rules, right? Lead is something that we've been able to at least focus on and understand the neurotoxicity of it and the long term implications of lead poisoning. We already have a structure, a legal structure that responds if a child's blood level tests above a certain level. The local Department of Health gets notice about that. And one of the really excellent pieces of our collaboration in Summit County, and actually covers many more counties because it's with Akron Children's Hospital, which has a large footprint, is that a legal aid attorney attends the Akron Children's Hospital Lead Clinic, which is a monthly gathering of families. Maybe it's 2 families, maybe it's 3 families. It's different every month. Families who are responding to their child having tested very high for lead, and what's the next step for that family. And so the hospital, of course, is responding to the individual child's blood lead levels and how to reduce them. The health department, if they're not already involved, they'll become involved with the issues around what's the housing look like? Is that the source of the problem? How do we ameliorate what's going on there? And legal aid will become involved if the landlord is recalcitrant in terms of remediation. And one of the other very fortunate things in our region is that we have city and county resources available for remediation of lead. I'd like to say that the processes are smooth and easy, but that would be an overstatement. However, they exist and can be negotiated, managed, and used to the benefit of our families. Go ahead. So I've been talking about this relationship with legal aid and Akron Children's, and we've been talking about the relationship with legal aid and the health department, and the potential opportunities for legal aid collaboration with community health centers. And these are all part of this model of a medical legal partnership that Bethany launched us off on in the beginning. And so, you know, what's a medical legal partnership? Well, it's bringing together lawyers in healthcare settings to help the healthcare providers address the root causes of poor health. Right? Not every health problem can be solved with a health solution. Some of them need, in addition to a health solution, a social or a legal push, and some of them are never going to be solved if you don't get to that next level of integrated wraparound effort. Go ahead, please. So we use this mnemonic in medical legal partnership land, I call it, called I help, to describe what is it that a medical legal partnership can do for you, because it does go beyond housing. So I have a chat question for you all. My chat question is, have any of you ever heard of the I help model for thinking about how legal aid can help solve a health problem? So if you just type in the chat, yes or no, we'll give you a second to do that.
So Marie, the question's in the chat and responses are coming through, and it's a mix of yes
I
and
see.
no.
That's great. I'm so glad. I see some familiar names as well. Hi, people that know me. So I'm gonna run through this to give those of you who have not heard of this an opportunity to just get a high level view of it. And there's fantastic information on the Medical Legal Partnership National Center for Medical Legal Partnership website, all kinds of wonderful resources. So I stands for income. And income is you know, how do we shore up the financial stability of a home? And so that comes into, we think about that really a lot in terms of public benefits, right? Maybe that's food stamps, maybe that's medical insurance card, maybe it's disability SSI or SSDI, maybe it's childcare. It's these kinds of things that improve financial stability for a family. Go ahead. And then H is housing and utilities. And so we've talked a lot about housing and utilities and how housing conditions impact health. But the other piece of housing, actually there's utilities, right? We've talked a little bit about lack of gas or lack of electricity, but there's also unstable housing, like you're facing potential eviction, right? Being homeless is a very unhealthy condition, as I'm sure some of you are aware of for the people that you're helping. So H is housing. E is education and employment, and we do a lot of work. Many medical legal partnerships work in the education space in particular, because we know that if kids can't get through K through 12, then it's going to be very hard for them to be healthy adults. So this is sort of it's a longer window, right? You want to have a good educational experiences so you have opportunities as adults. L is legal status, and we tend to think of that as whether you're a citizen or a non-citizen, and also whether you're a veteran, because those two groups of populations have a very specific set of rules that they navigate in their daily lives. Next one, please. And P is personal and family stability. And so this really focuses on domestic violence and intimate partner violence. So these are kind of all the areas where a legal aid organization may be able to help your families. And not every legal aid organization does every one of these things. There's a lot of nuance to how we say yes or no to a particular case, but this is the general picture of what legal aid does and how medical legal partnership impacts health. Go ahead, next slide. So who helps for those things? Well, I listed healthcare partners and legal partners legal services partners come together. And so this is sort of a menu, right? Pick one on A, pick one on B. There are lots of different ways that these come together, but the model is bringing healthcare partner or partners together with a legal service provider. And so what does that look like with a community health center? Well, that might look like we work in particular, for example, with the community health workers at one of our FQHCs who work with chronic disease patients. We work with primary care providers. We work with both doctors and advanced practice nurses in particular, and we work with the whole population health department with social workers and care coordinators at Akron Children's. So those are the kinds of ways. So community health centers have social workers, they have case managers, they have community health workers, they have advanced practice nurses, they have doctors, right? All of these providers exist within that framework, and undoubtedly see patients every day who would benefit from, who are struggling in these kinds of legal areas and would benefit from the opportunity to potentially work through some of these issues with legal support. Go ahead. Go ahead. So how do you start a medical legal partnership? So first of all, I have to say the resources at the National Center website are fantastic, and that is a place to go. They have toolkits. I mean, they have a kind of a workbook, and it really is fantastic, step-by-step. How do I get started on this? And these steps are kind of the basic beginning steps that are not rocket science, okay? You're going to identify the target, but they take time. You have to identify the target population. Then you have to identify, okay, who's the legal service provider in your community that can help serve that population. Then you have to begin the dialogue, and then you have to look for resources to support it. And some of the places those resources come from are local or regional foundations. Sometimes we'll fund a pilot, right? Let's see how this works. Sometimes we have funding in our legal aid organization through the VA. We also have funding from other federal grants through the Violence Against Women Act and through Health and Human Services specific to medical legal partnership modeling. And then there may be state grants. And the Ohio Department of Health has recently put out a grant that a couple of the medical legal partnerships in our state were awarded funds under, again, specifically for medical legal partnership. So this is a model that is gaining an understanding and popularity, and the potential of it is being, we're shifting from the potential of it to the actual really being able to witness these changes that can be wrought for our families. And just to bring it back around to where Sam left you, he talked about Buckeye Health Plan being very involved in the math program. And so that is also a triangulated, it's probably more than triangulated, but it's also a triangulated relationship in that Buckeye also brought us in, so that if those community health workers who are identifying households where there's asthma triggers and bringing the health department in to run the math program, they also have the opportunity to bring legal aid in to say there are other issues, whether they're housing or other issues that are getting in the way for this family's health. And so that's, again, part of that's a medical legal partnership relationship with the community health workers who work through the hub that we talked about briefly in Summit County. I think, look at that, 2:54. I'm going to stop. I don't know if you have questions, but I will turn it back over to Bethany for next steps.
That was great, Marie. Thank you to you and Sam. Let's get ourselves back on Spotlight and field some questions. So I'll just note, just remind folks, please feel free to type questions into the chat. And we can begin taking questions also via the Q&A. None in there yet, but I do want to highlight a couple of things for folks that we shared in the chat. And then I'll have a teed up question for Sam and Marie that might be helpful for folks who are trying to figure out what to do next if you aren't integrated as yet. Okay, so we shared the Health Center MLP toolkit. Marie referred to this and did a really great job highlighting some of the key steps for starting a medical legal partnership. If you click on that link, you'll get to the webpage on the NCMLP website where you can actually download that toolkit that walks through step by step, even what conversation questions should you have with your team, your partners, how do you develop workflows, how do you sustain it using an evaluation model, and then how do you use that information to further improve your medical legal partnership. So please take a moment to download that. You'll also see that we provided a link to the iHelp framework. And then earlier during the presentation, as Sam was sharing some highlights and data, we provided a link to the AAAF 2024 Asthma Capital's full report. Sam was presenting on 2019 data that led to the work that he was doing with Children's Hospital and will continue to do in the state. So speaking of work that will continue, Sam and Marie, we know that this work isn't easy. Collaboration across these different sectors, as well as we're talking about public and private sector, not just organizations. Would you like to share for the audience who may find it challenging in terms of where to start? Where would you recommend starting? Marie, maybe I can ask you, if you didn't know Sam, but you wanted to reach out to the county or the public health department, where might you recommend folks begin?
That's a great question. So I think that Sam and I found each other early on when we were trying to figure out who at the health department was working in lead space. And Sam, I don't know if he was closer to lead than he is now at that point. So that was how we found Sam. And then, it's Summit County is very collaborative. So it has never been hard to send an email or make a phone call and say, hey, I'm working on this. I wonder if you'd be interested in having a conversation with us and about how we might, align our work. Right? It's always best not to start out with, do you have some money for us to work together? It's always better to think about, okay, what is the relationship that we want to build, and then how is it that we want to bring that together? And so other places where where this connection has been made is we have a local medical school, and pharmacy and dental's coming. Pharmacy, dental, and a master's in public health program out of this medical school. And that's another place where they, once they start to think about rural health or social determinants of health or these pieces that if they're trying to think about, okay, how do we respond to social determinants, then if they have if we have relationships with people in the room, then they know to say, hey, you know what, legal aid does this kind of thing. And if we have relationships in the room, they know how to say, hey, I know this person who runs the Masters in Public Health program over at Neomed, and they would be interested in this. And so it really is about getting out of your office and getting out there and talking to the people who are in the space where you can make a difference for the people that you're trying to make a difference for.
Agreed. Sam, maybe I can ask you a slightly different question, because you work in a public health department and you mentioned, data sets, some that will come via the hospital relationship, some that will come from working with a health plan in the future. And, at some point, maybe legal needs data. Any advice for the legal aid organizations or even the health center folks who have MLPs formed with legal aid on what would be the best way to begin assessing data, sharing it, collaborating, and that around data with the public health department?
So it's interesting because there's going to be different levels of capacity for data handling depending on where you're at. Fortunately for me anyways, I live in Excel. That's my second home, is in a spreadsheet somewhere. But really just getting to know your colleagues, understanding what the issues are, having those frank conversations about what the needs are in your community, because that's going to build up your framework of what you want to kind of drive things towards. More data is always good, but too much data gets overwhelming.
Yeah.
So understanding where that line is to really push it forward, that's going to be the big driver.
Then you'll understand too what you need to share, because the lawyers will immediately say it's not that easy to share the data about the client.
Right.
And
Business
so will
agreements.
healthcare. That's right. Sam and Marie, we're right at the top of the hour, or the end of the last hour, I should say. And I want to, before we close out with the audience, sincerely thank both of you again for stepping away from your day-to-day work. And also thank the audience members for doing the exact same thing. These training and technical assistance resources and webinars and events that we provide really are to help the field better understand how they can work together collaboratively with old partners in new ways, or with new partners in better ways. So I want to thank you, Marie, as well as Sam, for helping us do exactly that. To the audience members, you'll see that Reha on the NCMLP team has shared a link to our post-evaluation survey, where you can share with us how this event went and how we can continue to support you with the creation of additional resources. On the screen, you'll see that we have several other events coming up. We just ask that everyone bear with us if any of these dates change. Through no fault of our own, we're doing our very best here. Everyone's going through a lot of changes around the country. So for now, on March 14th, you can join us to learn more about, we just talked about data in closing out the topic for today. You can learn more about information sharing and privacy essentials when we kick off a new MLP fundamentals group coaching sessions course. Then join us again on March 20th for a webinar on improving maternal health access and outcomes through MLP, where we'll hear from a team in New Hampshire that's working on perinatal cases and supporting individuals with substance use disorder through the perinatal experience. And then we're going to kick off starting in April. So sign up now, a new learning collaborative that is really well timed on getting the funding you need by building more effective messaging. So building effective relationships as well as pitches. That's also something that came up on today's webinar. Is really important in this environment where we're all hoping to obtain, maintain, and acquire and sustain funding to support our work. So sign up by March 28th so that you can join us when we kick that off on April 2nd. Just roll through the rest of these and you'll see that Reha is continuing to share the links to the Learning Opportunities page on our website. We also have the SDOH Academy Innovation Showcase competition that's underway, where we strongly encourage folks to continue on a on-demand learning journey on an LMS platform and take advantage of the opportunity to win a $5,000 advancement prize. So just all that's left is just going on the LMS platform to watch those training modules, take some really easy quizzes, get through it, and submit a very, very simple abstract describing your social driver, social determinants of health innovation that supports adolescents and young adults. Take advantage of that, everyone. Again, please fill out our evaluation survey. And we thank you for joining us today. You can use the QR code. Again, Sam Rubens, Marie Curry, thank you for joining us to let us know what great work you're getting done in the state of Ohio to support asthma patients in their health and well-being outcomes. With that, I want to also thank our colleague Hannah Silverman, who joined us today to support the tech on today's webinar, and we'll be closing out. Thanks everyone for joining us. You can find the recording online, and we'll be sure to share the links in a follow-up email. Have a great one.